This is the patient recruitment and outreach management overview presentation, focusing on where the solution is targeted, where we see it fitting in the marketplace, the main business needs and pains that were addressed with the screening programs for the BC Cancer Agency, some of the main benefits of the solution, and then we'll go into a demo of the solution as it's been built and exists here at Knowledgetech. Okay, so the solution for Canada is targeted in the public sector healthcare. It focuses, or the horizontal focus is client record management for recruitment and recall, as it's built today, which is specifically for screening programs or something, or a program similar to that. Has some workflow management, and should be expanding it to include scheduling, so client or patient scheduling for screenings.
So we don't have any scheduling?
Nothing's there today.
Okay.
No. Okay, so this definitely is a solution that can be a fit for other provincial cancer screening programs like BC Cancer, so Alberta Cancer, Ontario Cancer, Saskatchewan, any of those.
And our stuff at PHSA did not include cervical cancer, but
it did. Our stuff at BC Cancer Agency includes mammography, cervical, and colon check. So the three existing screening programs today.
What was the third one?
Colon check.
Colon.
Yeah. So they're all run by one entity, one organization.
Okay. Mammography, cervical, colon.
Yes.
Okay.
And those are the three programs that you'll find consistently throughout Canada.
Okay.
No additional programs exist today.
Okay.
For other types of screening. And colon check may not be running in some provinces because it's still early on, and most provinces are only running as a pilot program.
Okay. And I know we were talking before, we were saying this might also be a fit for other external screening programs. What would be examples? So
diabetes screening or heart health screening.
Okay.
So targeting at, or talking to the Canadian Diabetes Association,
right,
which is similar to the Canadian Cancer Association,
okay,
which could give you information on where there's programs throughout the country that might require this type of application.
Okay.
And then the Heart and Stroke Foundation or Heart and Stroke Association, those
right,
kinds of organizations.
Okay.
Could point you in the direction of what other, what services are being provided to screen for those kinds of diseases.
Right.
And then any organization focusing on preventative health care that needs to educate a certain population.
So what would an example of that?
So smoking cessation,
okay,
obesity,
right,
anything like that.
Okay, makes sense.
So the main business needs or pains that were addressed at the Cancer Agency, BC Cancer Agency, is that they didn't have a way to effectively recruit and promote regular screening to target populations. So there's an increasing challenge in reaching the majority of their target population, because before they relied on communicating through the primary care physician, so your family doctor.
Right.
And a lot of people today don't have a family doctor.
Of course.
So there's no way to get this information out, that that screening programs exist, when you should be screened, how frequently you should be screened, because people aren't seeing a regular provider.
Don't they also have numbers that they need to hit that the federal government tells the provincial governments to hit?
The provincial government and the screening programs together,
okay,
based on research and then all sorts of different information, background information, set a quote or set a target for how many people should be screened. So for BC mammography, for breast screening, 75% of their target population, and the target population is women aged 50 to 69.
What happens if they don't hit that target?
Their funding's reduced.
Oh, wow. Okay. Now, is it the same? Do we know if it's the same in Alberta and Saskatchewan?
It'll be roughly, their target populations will be roughly the same, because that's based on, so their target population is based on who's at most risk for this type of cancer.
Right.
So for breast cancer or for cervical cancer, whatever, where's the highest rate of occurrence,
Right.
and so that they screen most frequently during that period.
Okay.
So the province gives the program money to provide the screening. It doesn't go through MSP. It's directly out of healthcare.
Okay.
Out of the healthcare budget. So the provincial healthcare budget, which goes to PHSA. So they get a certain amount of money every year based on the number of people in their target population.
Right. Okay.
Okay. So they need a way to process a lot of data that they can get from the province of people living in BC that fit their target populations, but they need to be able to process all that data and then reach them with letters. Letters today, they might become emails at some point in the future.
Right.
Right, depending on what kind of information and security can be put around that.
Okay.
But it's letters today so they want to actually identify a individual and an address that they can send information to.
Okay.
They do general public marketing campaigns, but as soon as you start to fall on that target high-risk population, they want to be sending information about the program.
And why did they need to come to us for a solution then? I mean, shouldn't something like this have already been out there?
Right, so the solution, the clinical information system selected for PHSA, which is CERN,
Okay.
includes some of this functionality in the radiology information system module.
Okay, so in RIS they do have some...
In RS, they have it only for mammography or breast screening. It could not be applied to a lab-based screening program like cervical or colon check. So for breast screening, they do images, right?
Okay.
Right? So it's in the radiology information module.
Okay, I'm getting
And
you.
so for cervical and colon, it's a lab-based, they test samples that they take from the
Right.
patient, right? And you can't adapt a radiology information system to work for a lab-based.
Wow. So,
Right?
okay, so because
the
it
lab
crosses
information
LIS
system-
and RIS.
Yeah. Yeah.
Okay.
And LIS doesn't have the functionality.
Oh,
So-
okay.
And they don't want to completely customize the solution within Cerner.
So now, is the onus of meeting those target quotas to those programs, it's not with the radiology department, the onus of meeting this target. It's with the lab. It's with the screening program
Yeah.
who use the services of the radiology department or the lab.
Yeah, so they use...
So the lab
they-
doesn't
they-
have a
more than
burden
that,
of
they
having
use,
to do this.
they use the facilities. For breast screening, they use the facilities, but they put the people, like they pay, the clerks might pay their tax and they pay the radiologists.
Oh,
But they
okay.
exist throughout the province in these different facilities, whether it's a hospital or a private
Right.
imaging center.
Which is why you don't see a lab running out to add this functionality to their LIS, because it's
Right.
not their burden, it's the screening program's burden.
Yeah, exactly.
Okay.
Yeah, and for the lab-based programs, the central lab for PHSA here in Vancouver processes all samples from throughout the province. So for cervical, your family physician takes the sample and
Right.
sends it to the main lab,
Okay.
and they process it and do the results there.
Okay.
And then for colon check, the patient takes their sample and mails it in to the same lab, and they do the centralized processing.
Okay.
So there's no need for any other type of facility throughout the province to have this kind of a system.
Now this is different than the U.S. though. The U.S. has a completely different.
Yeah, yeah. There, the screening is done in all the diagnostic centers. So you go to your local hospital or you go to a imaging center and you are screened and you get your breast screening. And it are done and it's paid for by your insurer if it's provided in your insurance package.
And they don't have the need to meet these quantities for testing.
No, there's no central body that's driving that.
Okay.
It's just the physician recommending it to their patients.
So in
because
that
they
case,
get
it's in the best interest of the diagnostic lab to sell the physician to refer the patient to
Yeah.
come to their diagnostic lab, because that's how the diagnostic lab will get paid, and
That's what
the physician gets paid, and so really the whole thing on their side is being driven by the diagnostic lab wanting to service people.
It's the people that want to service and make the money,
right.
Whereas here it's getting the funding to provide the service.
Right. Okay. Gotcha.
Right.
Gotcha. Okay. Maybe we should move on.
There is some state funding in the U.S. So some states do receive funding for screening for uninsured
gotcha.
people. And I don't know with the new healthcare bill how that's going to change.
Okay. Next slide.
Okay, so the other challenge that they had, so one was processing all the data that they would get, building some business rules to process that data, and then actually mail out the letters. The other thing was they needed, the robust functionality for recruitment and recall, but it needed to have some interface and work with the clinical information systems. Both the legacy systems that were some were as old as 20 years old, as well as the ones that Cerner that would be replacing those legacy systems in the future. So whatever the solution was that they got for recruitment and recall needs to work today, and it needs to work 10 years down the road.
And that's for the patient. So the data that we're passing between these systems is the patient information.
Yes, and so a portion of the patient information,
right.
But more just the demographics.
Okay.
The clinical information does not exist and doesn't need to exist within the recruitment and recall system.
Okay.
The only thing the recruitment and recall system needs to know is who's the patient, how do we contact them, and when were they last screened.
Okay.
So that the rules know when to remind that person that they need to come back for screening again, or recruit them because they've never been screened.
Right.
Right? And their current information systems, as well as Cerner, which is planned for the future, could not process large batches of clients. So we want to recruit, say, 1,200 people in a month for breast screening.
Okay.
Or you want to remind 500 people every week that they're due back for screening. Most clinical information systems are based on working with one patient at a time. And they don't have that kind of batch processing.
Right, large volumes of people
exactly.
At once.
Yeah.
Gotcha.
Okay, so some of the major benefits of the solution is that it's going to help to increase participation in the program because we're more effectively reaching the target population. Right? Reduce the program management time required to recruit and retain client participation screenings. So there's a lot of manual processing to figure out when people were last screened, put them on a list to get a letter.
Okay.
Eliminate manual tracking and processing of recall them.
Okay.
Promote consistent processes for correspondence and response management through the use of workflows.
Right.
And then adapting to meet varying requirements and processes of different screening programs. So they roughly have the same process for recruitment and recall, but they have different business rules and parameters around how frequently patients should be recalled. Their patient populations are different, so it needs to be able to accommodate those things.
Okay.